We welcome Dr. Louis Breschi, a board-certified urologist in part-time practice at a large single specialty group in Baltimore County. He's the immediate past president of the Board of Directors of the Catholic Medical Association. Dr. Breschi has long been active in state medical society committees involving professional ethics and organized a separate ethics committee at the State Medical Society and at his primary hospital in the early 80s. Perhaps most impressive among his achievements, he's been married to a wonderful wife, Jackie, for 48 years, and they are blessed with 5 children and 15 grandchildren. Dr. Breschi, thank you.
Good afternoon, and Your Excellence, Archbishop O'Brien, Reverend Fathers, colleagues in healthcare here today, and other interested folks in healthcare problems. I'm honored and pleased to represent Catholic physicians and healthcare workers in this forum. As a member for 15 years of the Catholic Medical Association and a past president, I'm proud to present an outline of the Catholic Medical Association's journey through the healthcare legislation. I have prepared a synopsis of the CMA's position relative to the position obtained from the position papers and the medical articles on this topic. Our Chief Executive Officer, Dr. John Brahaney, was a participant and panelist for this symposium 2 years ago in 2009, and board representatives have spoken on this issue in many forums. My presentation includes many of the thoughts expressed in those presentations. The Patient Protection and Affordability Act, the PPACA, which Mr. Pigrillo has shown during his presentation, was presented to the public by making 3 significant promises. First, Americans' health insurance costs would be reduced. Second, the health law PPACA would reduce the rate of spending on health care and would not add to the national deficit. Third, people satisfied with their current health insurance plans could keep them. Each one of these promises has been or will be broken. The reason is that the administration did not address the underlying causes of health care problems, but focused on increased access to health care. They seek to accomplish this by mainly adding to Medicaid, a system already strained by inadequate funding and staffing. Physicians here and those nurses that may work daily day in taking care with people at times, or plenty of them who receive medical assistance, are well aware of this. And this has somehow escaped the planners in Washington that the system is the most unsatisfactory form of health care that we have, simply because the pay for the care is so minimal, and people and healthcare providers cannot afford to sustain that system because of the legislation and laws that we all have to abide by in practicing medicine. And so you have minimal care by a few people, and this is hardly the area of healthcare that you want to put people in large numbers, as has been indicated by the administration. In addition, the national insurance mandate, which is part of this, has raised constitutional issues and is now in the courts, as you all know. As important as the health care case cost bills involving the finances and constitutional issues are, the Catholic Medical Association, the CMA, representing Catholic physicians as well as other concerned Catholic healthcare providers, other than Catholic hospitals, has focused primarily on the harm that such a vast, vague legislation brings to the task of ongoing moral and ethical delivery of health care. Since the discussion of Obamacare began in 2009, the Catholic Medical Association has taken the position of advocacy for defeat of this bill because it was a slipshod partisan bill that ultimately was passed against the will of the American people. The reason that the Obamacare fails to respect fundamental, ethical, constitutional, and social principles. Since the passage of this bill in 2010, we believe the results support the CMA position. The issue of funding for abortion is paramount, but has already been addressed by Mr. Piccirillo. But a second, which he's also addressed, but even for us is even more serious, a second very serious concern is the lack of protection of conscience rights for healthcare workers. By the way, I thought one of the things that was failed to mention is one of the areas in healthcare that is really in the area of conscience that is not said much of, but puts them in very tight and difficult positions, and that's the plight of pharmacists in this country who have their rights to not fill prescriptions. That is a significant area of healthcare that this conscience thing has not addressed. Regulations enacted under the Bush administration to uphold federal conscience protection laws, such as the Hyde Law, the Hyde Amendment, and the Weldon Amendment, among others, are expected and may have already been revoked by the current administration. President Obama began the process of rescission 2 years ago in March 10th, 2009. That's just 2 days, 2 years from almost a day, when he signed a notice of proposed rulemaking to rescind the Bush Conscience Protection Act. A third major social ethical principle that has not been addressed, but very important to healthcare ethics, is that of subsidiarity. The Catechism of the Catholic Church, and its item number 1883, defines subsidiarity as follows. A community of higher order should not assume the task belonging to a community of a lower order and deprive it of its authority. It should rather support it in cases of need. Excessive intervention by the state can threaten personal freedom and initiative. Pope Benedict XVI wrote in the 2005 encyclical, Deus Caritas Est, quotes, "We do not need a state which regulates and controls everything, but a state which, in accordance with the principle of subsidiarity, generously acknowledges and supports initiatives arising from the different social forces and combines spontaneity with closeness to those in need." The principle argues for a healthcare reform solution which fortifies individual family responsibility for health-related decisions. The doctor-patient relationship should be strengthened and protected rather than threatened by distant bureaucratic panels. Local or community-level initiatives should receive priority over increasing the role of more distant employer government control. The need for healthcare reform is unquestionable, but is the near total discarding of the present system in one gigantic bill correct? The size and complexity of healthcare as we know it in this country does not lend itself to such a sweeping change. Government leaders can and must enact healthcare legislation that respects our deepest human and constitutional rights. the right to life, respect for conscience and religious freedom, that respects the patient-physician relationship, and fosters innovation and quality in medical health care, that respects the principle of subsidiarity in decision-making across the spectrum of choices in health insurance and healthcare services, that ensures that all people have access to health care, particularly the poor and vulnerable. Finally, do this in a way that is economically sound and sustainable. Currently, this is not attainable with the Obamacare bill. So where do we go from here? Well, first, good health care legislation should strive to make health care affordable both to patient and society, and also be quality care. Secondly, the dignity of each person must be protected from conception to natural death. There should be no subsidy for abortion or abortifacient contraceptives. Third, strive for the common good by working to improve social conditions that make insurance affordable and available, such as the laws to allow cross-state line purchases of insurance, which would bring in some competition on the cost of insurance care. Fourth, to support the principle of subsidiarity by supporting efforts to enable individual and families to obtain health care in the marketplace, not from a government bureaucracy. Finally, virtually all right-to-life organizations have been supportive of either voiding the current health care legislation or making more and proper significant changes of the present law. The official Catholic position needs to be uniform and total in its support. The USCCB, the Community of Bishops, position of opposition to Obamacare unless significant amendments and conscience issues are included is a very strong position. The Catholic Medical Association concurs with the bishop's position and would further support more recognition of the principle of subsidiarity. This collaboration is not complete in our Catholic healthcare system. And this was addressed at the very end by Mr. Piccirillo, and I bring it up also. But this lack of unity has been confusing to the laity and to politicians. We hope that the Holy Spirit will guide us in the future in these worthy goals together. Thank you.
Thank you, Dr. Breschi, and thanks to the Catholic Medical Association for all they're doing to inform and to promote good ethical practice in the medical profession and explain that to the public at large. I'd like now to welcome Dr. Marie Hilliard, PhD, JCL, RN. Dr. Hilliard holds graduate degrees in maternal child health nursing, religious studies, canon law, and professional higher education administration, and she has an extensive professional background in medical ethics and public policy and advocacy. Dr. Hilliard is a registered nurse who has been involved in healthcare regulation at the state and national level for 12 years. In addition, she's a canon lawyer and serves as a resource for the USCCB on implementation of the ethical and religious directives for healthcare, Catholic healthcare services, as well as church-state relations. As a retired colonel in the United States Army Reserve for 20 years, and I knew Dr. Hilliard way back, Dr. Hilliard was the acting deputy brigade commander of the 5th Brigade, 98th Training Division, responsible for all United States Army Reserve medical training for the Northeastern United States. She has been recognized by the Army for her contribution with the Meritorious Service Medal. She has served as an advisor to the United States Conference of Catholic Bishops on their task force on Catholic bishops and Catholic politicians. Welcome, Dr. Hilliard.
It's always good to be with Archbishop O'Brien, my former ordinary, when he was Archbishop for the Military Services. So thank you very much for that very nice introduction. What I'm going to be doing in my segment is basically talking about the impact of, we're calling it PACA, the healthcare reform legislation, in terms of how it's interfacing with the state mandates. There are many, many state mandates impacting our practice. You heard I am a registered nurse. In your materials, you don't have to pull them out now, but I have given you several pages of charts that show state by state the number of mandates impacting our practice in a number of areas, from assisted suicide, terminal sedation, of course, is just another form of that in terms of, and it can be exercised very morally, but it also can be exercised in a way that it's just a euphemism for assisted suicide. So you have those charts. But before I actually begin, I want to thank the Archbishop, because in the last 3 years that he's been running these symposia, it's very clear to me his commitment to Catholic healthcare, and there's a significant presence of Catholic healthcare in the Archdiocese of Baltimore, and this is a significant commitment of his time. I worked in the Chancery for 10 years when I was State Catholic Conference Director in Connecticut, and I know how busy bishops are. And he's also, he's alluded to it, but I think he's batting 1,000 in terms of your state legislature here. You had a big win yesterday in terms of defeating mandates for recognizing same-sex marriage, and that does have implications in terms of health care also, which I will be addressing when I give you some examples at the state level. And also your success with the crisis pregnancy centers in terms of the free exercise of religion and First Amendment rights in terms of what we need to present in terms of the services that are provided. So you're batting 1,000, Archbishop, and I thank you. And it's so important in this state. This state is the bedrock of religious liberty. Folks came and settled in this state for liberty, particularly religious liberty. But what we're beginning to see is those of us who claim the right to the free exercise of religion are being labeled as violating the separation of church and state. And nothing could be further from the truth. I have a quote here from a wonderful scholar. He's a constitutional law professor at Yale. And from my understanding of Stephen Carter, who's written several books, one of which is The Culture of Disbelief, and he talks about the secularization of our society. And from my understanding, he is not a Catholic, but talking about how the First Amendment is being used against us. And if you'll allow me to quote from him, "For the most significant aspect of the separation of church and state is not, as some seem to think, the shielding of the secular world from too strong a religious influence. The principal task of the separation of church and state is to secure religious freedom," end quote. And tragically, the very government, born out of the need to secure liberty, particularly religious freedom, is beginning to impose policies that impact our free exercise of religion, and impacting policies not only on the most vulnerable, the unborn and those at the end of life, but those of us who want to protect them and care for them. And we're seeing state by state those mandates. I'm Director of Public Policy at the National Catholic Bioethics Center, and we run a 24/7 consultation service. It's free, and we get about 1,400 calls per year. A doctorally prepared bioethicist is on call. And increasingly, we're getting calls from young women and men who want to go into healthcare, be it medicine, nursing, pharmacy. Can I go into this profession because of these mandates? And again, those of us trying to protect the most vulnerable in our society are finding us accused of violating the separation of church and state, and I'll give some examples. But these attacks clearly are escalating. I never thought when I entered nursing school, I went to Children's Hospital in Boston for my RN, that was a non-Catholic nursing school, and I remember we were affiliated at what's now Brigham and Women's. We did our adult and our PD, our OB, what is now Brigham and Women's was Peterman Brigham and Boston Lying In. But I remember as a young student nurse at Boston Lying In being asked to go into a room where they were inserting an IUD, and I refused. And I got away with that, but I wonder today if I would be able to get away with that. So again, these threats are escalating, and we're very concerned with the Patient Protection and Affordable Care Act, and as Dr. Breschi has mentioned, the recent rescinding by President Obama of major portions of President Bush's conscience rule. This will have a tremendous impact on our practice. And again, we're living in a culture which has embraced secular relativism, and we're seeing this culture that was always supportive of the wonderful ministry of Catholic healthcare becoming hostile to religion, and particularly to the Catholic Church. And the Catholic Church is the largest provider of non-governmental health care in this country, also of social services and also of education. The largest provider. Everybody thinks it's the American Red Cross or the Salvation Army. Catholic Church does it all. And I just have, if I can bore you with some statistics, but they're important. There are 561 Catholic hospitals in the United States treating annually over 68.5 million patients. 68.5 million patients. And that doesn't account for the other 2,331 other healthcare ministries that treat almost 11 million patients annually, like your surgery centers, your group homes, et cetera. Again, as the largest provider, we are critical to the well-being of this country, and yet increasingly there are laws and regulations that would appear to be hostile to our ministry. We're not only the largest, we're the oldest. The Archbishop talked about me being Deputy Brigade Commander for the Northeast United States in terms of all Army medical training. And I ran their schools of nursing and their medic training. And in all those textbooks, the history of healthcare tells us that we are the oldest form of organized nursing and the oldest form of a system of delivering healthcare. St. Benedict in 500 AD, the Benedictine nursing order, in the textbooks, the oldest form of organized nursing. How many of you are Malta? Anybody here? Doctor, I know you from our trip to Rome. The oldest organized form of healthcare delivery at hospitalers, 1113. And right here, your own Elizabeth Ann Seton, St. Elizabeth Ann Seton, the first hospital west of the Mississippi, her sisters in St. Louis in 1830. Healthcare in this country and Catholic healthcare are synonymous. We're responding to the message of the Good Samaritan, and yet those who are promulgating laws and regulations are treating our ministries as if we are just agents of the state to do what they tell us to do in violation of the very tenets that brought us into our ministries. And that's what we are seeing. And how this impacts with the Patient Protection and Affordable Care Act, I'm going to address now. Attorney Piccarello said he didn't want to get into the weeds with you in terms of some of the permutations, but it is undeniable that, and we talked about this later because it is complex, but I just want to make one point. It is undeniable that the Act does fund programs that provide abortion. Now, they have created this mechanism where if you opt for a health care program or plan within your region that doesn't have abortion, and there are only one in each region does not have to have abortion in it. The law says at least one program in every region will not provide abortion. But what if the one that's best for your family is the one that does? You will have to write a separate check every month for the abortion part of that plan, whether you're going to use that at all. So they tried to, it's smoke and mirrors in terms of, no, we're not funding abortion, but they're funding programs that provide abortion. You write your separate check. And it's highly likely that there will be direct pay for abortion in those plans that Attorney Piccarello identified. The $11 million for the community health care centers, although we did see where Secretary Sebelius said, no, this, you're not going to do it, but it was only after it had already been approved and it was brought to light. The high-risk pool program, actually that was the one in which she had said no after the Department of Health and Human Services had already said yes. And also the cooperative grants program. There are 3 programs in which there is the possibility, highly likely, for direct funding of abortion. And the executive order, which the Attorney Piccirillo had referenced, that President Obama issued, if the protections are tenuous at best. And if I can read the second to the last paragraph from that executive order, it makes very well Attorney Piccirillo's point that it doesn't carry the force of law. This is what the executive order finishes with. This order is not intended to and does not create any right or benefit, substantive or procedural, enforceable at law, or in equity by any party against the United States, its departments, agencies, or entities, its officers, employees, or agents, or any other person. End quote. Thus, it doesn't create any new law. In fact, again, Attorney Piccirillo mentioned this, it mandates that essential health benefits be provided in every exchange in the country. And already, the question of what did this mean in Medicaid has been to the Supreme Court, and the Supreme Court has said when that language is used that abortion fits within, and I'm quoting, many of the mandatory care categories, including family planning, outpatient services, inpatient services, and physician services. This was in a Supreme Court decision, that if you use that language, preventive services, that abortion is included. And that was the reason for the need for the Hyde Amendment that Attorney Piccirillo has stated. But it has to be enacted every year, and it has to be enacted in a way that it is very specific to what programs it is to be applied. And it's not in the Patient Protection and Affordable Care Act. In fact, as Attorney Piccirillo has stated, every meaningful amendment that was offered to remove abortion from the Act was defeated, failed. And you heard about the Stupak Amendment failing. There are, however, 2 provisions in the Patient Protection and Affordable Care Act that do protect conscience, and they themselves are problematic. It does say that no individual provider or agency or entity will have to provide or assist at abortion. It says the same in terms of assisted suicide. But the problem is, how is abortion defined? And one of the questions that was already raised in terms of the nature of abortifacients and the redefinition of conception. So what we're seeing historically, what has been understood as what an abortion truly is, redefined. And historically, abortion was anything that caused the expulsion of an embryo or fetus from the uterus, from the reproductive system, from the moment of fertilization, not just after implantation. And ACOG, the American College of Obstetricians and Gynecologists, redefined conception to mean implantation, not fertilization. Yet from the moment of fertilization, a human being exists, which could be 10 days before implantation. So we have seen that abortion no longer is defined legally as to what it truly means, even though scientifically, from the moment of fertilization, that is a human being. And we've seen in states in which assisted suicide has been made legal that assisted suicide cannot be listed as a cause of death on the death certificates. So, in fact, that's both Oregon and Washington. In fact, the Oregon state statute specifies that actions taken in accordance with their Oregon Death and with Dignity Act do not constitute suicide, mercy killing, or homicide under the law. So you see with these protections, it's tenuous at best because of how abortion and assisted suicide are defined, particularly when we get to state laws. So without the Hyde-Weldon Conscience Protection Amendment, which is in our Health and Human Services funding legislation, of which the Patient Protection and Affordable Care Act is separate and distinct, that language is needed in this legislation, and it is not there. And the scenario becomes even more ominous with last month, the rescinding of major parts of President Bush's conscience rule by President Obama. And I know some of you, because we talked earlier, have been at the hearings that have been held at the Institute of Medicine that Attorney Piccirillo has referenced in terms of what will constitute preventive services. And if you look at the panel they convened, the deck is clearly stacked. Panelists who have been involved officially with Planned Parenthood, panelists in their resumes talk about being involved with Merger Watch, panelists who are clearly advocating not only that preventive services must include contraception and abortifacients, of course, by default, although they don't define them that way, but also mandates to include these services which impact us. Because the conscience rule that President Bush had invoked and promulgated had a broad conscience protection for all lawful medical procedures and research. And President Obama has stated, no, it will only apply to abortion and surgical sterilizations. And again, there is no definition of abortion in the conscience rule. And it's interesting if you look at how the process occurred, because in the conscience rule rescinding or partial rescinding, there was a notice of intent, and 300,000 responses were sent in to the Department of Health and Human Services on this, 300,000. You'll be amazed to hear how many asked the Health and Human Services to retain Bush's rule. 187,000. More than half said, wait a minute, retain this Bush rule, it's good. And yet the major parts were gutted, despite all that input from those of us particularly impacted by it. The impact on Catholic healthcare, and all healthcare workers, they're persons of conscience, and I'm going to give you some examples, though I don't even think are Catholic, who have been impacted by these mandates. It's particularly true, and will be, with the Patient Protection and Affordable Care Act, in regions of the country where the Catholic healthcare is the major provider of healthcare. When you go out west, the population is much more non-Catholic, and the healthcare is much more Catholic. I was speaking in Oklahoma, and that's an area of the country where there's Catholic healthcare is healthcare for that state, and the population clearly is, a Catholic population clearly is a minority. Yet, despite that, we hear there's no need for us to be concerned because there are existing laws that protect us in terms of our conscience. But I'm going to give you some very specific examples to the contrary. A Catholic hospital this was out in California, was sued for initially refusing to provide breast augmentation therapy to a transgendered person. Now that's why you're fighting and there are very few protections, I understand, in the same-sex marriage law for religious liberty that you succeeded in defeating yesterday. This was an evangelical physicians group. They were involved in IVF, which of course we would not condone under natural law, but they were a fertility practice that said we only want to do our care for persons who are married because children do best in a home with a mom and dad. And a lesbian couple approached them and wanted fertility treatment, and the California Supreme Court told them in their decision that they must provide that service to the same-sex couples. In another example, this is a nurse in Louisiana. After 4 years, she's finally got her day in court after she refused to administer the morning after pill, emergency contraception, and she lost her full-time job because she refused to do that. 19 states have legal mandates for the administration of emergency contraception, which would also serve as abortifacient for cases of sexual assault. Now, our Catholic hospitals will give it, but with appropriate assessment, physical exam, laboratory data, to make sure that it's given at a time where it won't prevent the implantation of a conceived embryo, that it can have the potential for stopping ovulation. We know of a New York nurse who was forced to assist at an abortion. In New York, she was threatened, and she had given all appropriate notice, even upon hiring, that she would not do so. And she was threatened with action against her license if she refused to participate. And just recently, the courts have decided that she had no right of private action against her employer. Professional associations like the American College of Obstetricians and Gynecologists have stated that conscience can only be accommodated after the duty to patient is met. Well, that means, yes, we give our advance notice. We say what we will and will not do. I've said no many times in my life. We don't abandon patients. We let people know ahead of time what we will or will not do. But here's what ACOG says. Specifically, physicians of conscience not only must refer to other providers. That doesn't mean transfer cure. That means tell someone else to do what you wouldn't do, which is, of course, morally not licit. They must, in resource-poor areas, locate their practices near providers who will do the morally illicit procedure, and in an emergency, provide that procedure. However, there is some good news. Nurses in Nassau University, this is Long Island, Nassau University Medical Center were able to get their labor union to support them, 8 of them, in their refusal to assist in abortions. It's again about standing up. But the American Medical Association's Board of Trustees issued a statement saying in part, and I quote, "Our AMA supports legislation that would require individual pharmacists and pharmacy chains to fill legally valid prescriptions or to provide immediate referral to an appropriate alternative dispensing pharmacy without interference," end quote. In only 9 of the 25 states with pharmacy mandates, and there are 25 on this issue, in the dispensing of emergency contraception, provide true conscience protections, and 5 of these 25 states have mandates that a pharmacist must fill every legally valid prescription. One of those states is the state of Washington, in which physician-assisted suicide is legal. And here's what's very disturbing. There's a religious coalition for reproductive choice, and these are clergy persons. They admonish that the law should not be overridden by positions of conscience that are based on religious beliefs. Think about oppressive regimes that have led to horrors in terms of the violation of human life if we just followed the law and weren't able to follow our conscience. Blatantly seen in 2 states, New York and California, that's been to the highest court in both of those states, where Catholic hospitals, Catholic charities, and other Catholic institutions are being told that the only health care plan they can get for their employees must include contraceptives and abortifacients. Because to be deemed a ministry in those states, they must only hire Catholics, only serve Catholics, and proselytize. That's the only way you could get an exemption and be calling yourself a religious entity. So that would mean at St. Joseph Hospital here, if that were true here, you'd have to check baptismal certificates at the emergency room door with the insurance card when you're receiving a patient. And what's disturbing is there are a total of 7 states that have that kind of definition of what it means to be a faith-based entity and therefore eligible for exemptions. And I ask, where is Thomas Jefferson when we need him? And this is his quote: "Our rules can have authority over such natural rights only as we have submitted to them. The rights of conscience we never submitted. We could not submit. We are answerable for them to our God." Thank you very much. Mm-hmm.